Hi, I'm Dr. Sadie Larson, clinical psychologist and member of the ISTSS Public Information and Education Subcommittee. One of the goals of ISTSS is to disseminate knowledge to improve access to quality care for people who experience traumas. As part of that goal, the ISTSS Education Committee collaborates with people who developed or implemented the interventions highlighted in the ISTSS Child Psychological Treatment Guidelines. We hope to support widespread implementation and dissemination of those recommended interventions. And today I'd like to welcome Dr. Esther Deblinger, who, along with Doctors Judith Cohen and Anthony Mannarino, developed trauma-focused cognitive behavioral therapy, which was identified as a psychological treatment intervention with a strong recommendation in those guidelines. So welcome, would you like to introduce yourself?
Sure. My name, as you said, is Esther Deblinger, and I am the founding co-director of the CARES Institute at Rowan Virtua School of Osteopathic Medicine, where I'm also a professor of psychiatry. And as you mentioned, I had the great good fortune of meeting Doctors Cohen and Mannarino over 30 years ago at a conference sponsored by the National Center on Child Abuse and Neglect, where we essentially discovered that we were developing very, very similar treatment models for the same population. We were focused on helping children who'd been sexually abused. And in that moment, I made probably the best decision of my life. Although maybe I shouldn't say that. The best decision of my life was marrying my husband and having two beautiful children. But my best professional decision was collaborating with Doctors Cohen and Mannarino. It made sense for us to engage in treatment outcome research that was including more children. And by doing multi-site work together, we were able to conduct studies that have been, very effective in representing children who've experienced post-traumatic stress disorder.
Excellent. And would you tell us a little bit more about that intervention? What are the specific goals and the key components of the intervention?
Well, of course, the primary goal is helping children who've suffered not only sexual abuse, but today any of a wide array of traumatic experiences to overcome those experiences, to essentially avoid developing some of the negative lifelong effects that coincide with developing post-traumatic stress disorder or depression, or sometimes children develop behavior problems as a result of trauma in childhood. So we have been very successful in documenting that this treatment model is able to help the vast majority of children reduce difficulties in the area of trauma and also help their caregivers. It is a treatment model that is very much focused on not only assisting children and adolescents, but also assisting caregivers in helping them overcome the stress that they experience when their child has suffered a trauma, but also helping them be effective role models and helping them to nurture and parent their child in a way that will help their child blossom despite the traumatic experience that they suffered.
So important to help children and their parents. And so what would they mainly expect to do in this treatment?
Well, so there are essentially three phases of treatment. We start out with a focus on stabilization and skill building, and then move into trauma narration and processing. And in the final phase of treatment, we help children and their caregivers consolidate the skills that they've learned and integrate what they've learned into their life ongoing. The components of treatment are summarized by the acronym PRACTICE. And they include P for psychoeducation. We start out with helping children and their caregivers learn about the impact of trauma and learn about the structure of the treatment. And we focus on parenting throughout the model. And then we move on to the R in practice, which stands for relaxation, and the A, which stands for affect expression and modulation. Just simply learning to express feelings in words, that helps children. They're much better off expressing their feelings in words than in behaviors. So we focus a lot on that. We then move into cognitive coping, the C in practice, and then trauma narration and processing. So you could see how we build the skills first before we really engage children in processing their traumatic memories. And then finally, for some children, we do in vivo mastery work, and we engage in conjoint sessions where parents and children are able to communicate openly about a traumatic experience that sometimes children have told no one about. It's very important for them to get comfortable being able to talk to their parent about it. And then finally, we work on enhancing safety. The safety component sometimes moves to the beginning if we're working with a child who, for example, may still be in a somewhat unsafe situation, whether the issue is sibling abuse, where they're still living at home with the sibling that may have abused them, or if there is, a great deal of community violence where having those safety skills might be helpful at the beginning of treatment. So it varies sometimes where we engage children in the safety component.
Right.
When
And I am much more familiar with adult interventions and less so with child interventions. So I'm very curious with the trauma narration portion of this. Is that a verbal narration? Is it a written narration? What does that look like?
Yes, it very much depends on the child. And I have to say that unlike adults, where you could explain to them why engaging in a difficult therapy process will ultimately be good for them, kids don't buy that. So we have to
Yeah.
approach it gradually with children. And so we don't ask them right away to start talking or writing about what they've experienced because they don't want to do that. We start with psychoeducation, where the therapist models talking about the traumatic experience that they may have suffered. And the parent also. It allows children to feel comfortable in a more gradual way. And each session will talk a little bit about why they're coming to treatment. So by the time they get to the middle phase of treatment, they're really ready to share their experience. And sometimes it's in discussion and sometimes it's in writing. Sometimes, children who are inclined to want to sing, they'll do lyrics that describe their traumatic experience, and that makes it easier for them. So we really encourage therapists to use their creativity in the context of engaging children. Children do much, much better when you engage them with art and play, and you make the process appealing to them.
And the parental involvement that you've mentioned being important, is that a little bit in every session? Is that more in certain phases than others?
Oh, I'm so glad you asked that. We are so committed to caregivers being fully involved that we encourage caregivers to spend half the session with the parent, half the session with the therapist, and the other half is devoted to the child. Parents can be so critical to healing, and they're suffering too oftentimes. When something awful happens to your child, it's very painful for the parent. And TFCBT research, which there has been a great deal of. In fact, there have been 25 randomized trials. And in that research, we've documented that the caregivers also benefit. Their levels of depression come down, their parenting skills improve. They get great benefit from participating, and ultimately their children benefit as well.
Yeah, that makes a lot of sense. And one of the questions I ask, which I think you've already sort of touched on, is typically, is there a specific target population for this? It sounds like when you were first developing this, you were targeting children who had been sexually abused, but at this point, it's much broader than that. Is that right?
Yes, absolutely. The first few studies were with children who'd been sexually abused, but today TFCBT is used with children who've experienced a wide array of traumatic events, including exposure to domestic violence, community violence, natural disasters, man-made disasters, children having experienced really almost any kind of adversity can potentially benefit from TFCBT.
Okay, that's really helpful. And how do you think about measuring treatment outcome to know if this is having the effect that you want?
Well, I think it's very helpful for therapists to use standardized measures. And for measuring post-traumatic stress symptoms, there are a number of different measures, including the Child Adolescent Trauma Screen, which is the one that we use at the CARES Institute. Others use the post-traumatic stress disorder index. There's another measure called the post-traumatic stress scale for children. So there are a number of different measures that are valuable. I also think it's helpful to use a measure of behavior problems because many children who've experienced trauma suffer behavior problems. So we use the child behavior checklist or the pediatric symptom checklist. If a child seems to be suffering depression, you might use the child depression inventory. So there are a number of different measures that can be valuable. But, I find that one of the most striking measures is to see the change in children's narratives over time. Once they get to the final stages of therapy, you see a magnificent positive change in the way they're talking about what they've experienced, the way they're talking about themselves, their relationships with others, and even the way they talk about their future. It is, so much more optimistic typically, and you can see that they've made a change in their thinking.
Okay, so it's a mix of those objective measures and listening to how kids are talking. Yeah.
Absolutely. You even see sometimes change in their behaviors where children
Mhm.
start out with, shame-like behaviors where they're hunched over, their heads are down, they're displaying discomfort in just being themselves. And by the end, they look different sometimes. Parents as well.
Mhm. Okay. And how do you think about ensuring that this is culturally sensitive for diverse populations?
Well, TFCBT has been used all over the world with children in many, many different countries across the world, including Norway, where they've done some magnificent research, including Germany, several countries in Africa, Tanzania, Zambia, the Democratic Republic of the Congo. So there are some differences when we apply TFCBT with different families in different countries from different cultures. But they're primarily differences in the coping strategies that they may use. There may be more of a focus on spiritual coping in some cultures. In some countries, we found that group TFCBT is a more natural way to approach healing and therapy. Cultures that are more collectivist in their approach and attitudes tend to want to do group TFCBT, and that's what they did in the Democratic Republic of the Congo with great success, and several other countries as well.
Mhm. So some of the structure or the way that people cope or deal with trauma might be different, and yet the overall approach to treatment is similar.
Absolutely. It's very consistent across cultures.
Yeah. Okay. And as you think about implementing this intervention in new places, if a clinician wants to start using this treatment, where would you suggest they start? What do they need to have in place to do this effectively?
That's a great question because we happen to have colleagues at the Medical University of South Carolina, Dr. Ben Saunders and Dr. Dan Smith, who, in collaboration with Tony Judy and myself, developed a online web-based training. So we always encourage therapists interested in getting training in TFCBT to start there. It's easily accessible. You just go to TFCBT web and you can find 11 hours of training. It provides CE credits and it's a great place to start. From there, though, we also strongly urge therapists to get in-person or virtual training where there's some interaction with the trainer. And we have trained many, many trainers across the world to provide this training. And it typically is several days of training. And then in addition to that, very importantly, we urge therapists to do ongoing consultation as they are implementing TFCBT with children.
That seems to be similar across a lot of therapies, that it's good to get some initial training, but it's really helpful to get that case consultation.
We recommend at least 12 consultation calls, and typically they're with other therapists. So you're learning not only from implementing yourself, but also from hearing about how others are implementing TFCBT with children and their caregivers.
Yeah, that makes a lot of sense. Um, and what about, so that's sort of getting started. What do you think is necessary to really ensure the sustainability of this intervention to be able to keep doing it over time?
Yeah, that's a great question. It is actually the question that we've been focused on more recently from a research standpoint. For 30 years, we've been researching TFCBT. And as I said, we have many randomized trials and many publications that have looked at therapy mechanisms and helped us better understand how TFCBT works. However, we've noticed, despite the widespread training, that when we go back to an agency or we're invited back to an agency to do training again, they've lost half their staff.
Mm.
And unfortunately, we believe that is because this is very hard work. It's difficult to listen to children's traumatic memories, especially around interpersonal violence. And it takes a toll. And so more recently, we've focused on how we can help mental health agencies that serve the population of children who suffer trauma and their teams. And what we have been focusing on is reducing rates of burnout, of secondary traumatic stress, and of turnover among clinicians. And we're finding that it's very, very important to not only provide good support in the form of, training in effective models and good support in the form of supervision and group consultation, but it's also important to focus on encouraging self-care and relationship care. We have developed a program that basically follows the principle of practice what you preach. We encourage therapists to use the skills that they actually teach their clients. And we encourage organizations to provide support for that. So we've referred to it as the practice course because it follows the same coping skills that we teach in TFCBT. But this time it's designed to enhance personal, professional, and organizational well-being.
I'm so glad to hear that you're looking at that because I think, yeah, whether it's adults or children, there is that same issue that it is very challenging work to do. And we have to think about how do we support providers in being able to continue to do this in a long-term way. So glad to hear that you're looking at that.
Yeah. And we're seeing some success. We've published some of our work and it looks like it can benefit. We're really interested in seeing, as you said, if we can sustain the benefits. Like anything else, it's hard to develop healthy habits and then it's hard to maintain them. And so we're just at the beginning of that work, and I hope that we can support people to stay in this field long term.
Absolutely. Well, that may get into my next question, which is really around what challenges or lessons you've learned from implementing the intervention. Any other advice that you would give for either agencies or clinicians who are thinking about using this?
I love that question because I've learned a great deal from my work. It's very lucky in a way, as much as it's hard work, it's also very lucky to work in a field where you're learning all the time. Probably the greatest thing that I've learned is the incredible resilience of the human spirit. When you see children go through extraordinarily difficult experiences, and yet they overcome, and you see their parents support them along the way, you begin to believe that anything is possible, really. It's very rewarding work in that way. And I would say in terms of the challenges, I think one of the challenges working in the child field is really being sensitive to development. The same thing that will work with a 16-year-old will not work with a 3 or 4-year-old.
Yeah.
The same explanations will not work. And I actually learned this many, many years ago from a little girl who was only 5 or 6 years old at the time. And she asked me, she was sexually abused, and she asked me, "Why did Daddy do this?" And as I began to think about what I was going to say and explain that it's a problem sexual behavior and her dad had a inappropriate attraction, I realized, what am I saying? She's 5 years old. So I turned it over to her and I said, "Well, wait, you tell me why you think Daddy did that." And she said, "I think he did that because he wanted to, even though he knew it was wrong."
Mm.
And I thought, wow, that is so developmentally appropriate. There's
Yeah,
nothing to correct there. I
yeah.
just, yes, I think you're right. On the other hand, she might have said, and we have had children say, "I think he did that because he thinks I'm sexy or I'm too sexy."
Mhm,
That's a problematic thought
mhm,
that we need to
mhm,
get in there and look at and perhaps challenge, because we don't want a child to start thinking that, if they dress in a certain way or they look a certain way, that somebody's going to sexually assault them. So it's really about having this communication and eliciting from children what it is they are thinking before
mhm,
you jump in and you provide information. And we really try to wait till we get to the trauma narration and processing stage where we've already elicited what children are thinking before we challenge anything. Because you don't want children to be trying to guess the right answer. You want them to be revealing to you their innermost and worrisome most thoughts and feelings. And
mhm,
then at that point, after they've really shared the details of what they've experienced, their thoughts, their feelings, later in treatment, we begin to look at and support those that are healthy beliefs, like that little girl who explained why she thought daddy did that.
mhm.
And on the other hand, towards that stage of therapy, we begin to help them correct unhealthy beliefs that can really cause difficulties for them in adolescence and adulthood. Sadly, sometimes thoughts that develop early in childhood stay with children
Mm.
across their lives and can create
Yeah,
havoc.
yeah. And so it sounds like for me, again, as someone who works with adults, I might find that I'm in this treatment giving people more time to just say what they think without getting into the challenges until a later point in treatment, whereas I might want to jump in more quickly with those challenges.
Right, right. Yeah, we really think
Mhm,
it's important that children have space to reveal their innermost thoughts and
mhm,
feelings before we begin to challenge them. Because, children like to please adults. So if
yeah.
they think they're getting the wrong answer, they're going to keep
Mhm,
correcting themselves. We don't want them to do that at the early
mhm.
stages of treatment.
Yeah, yeah, that makes a lot of sense. Um, and I'm curious because you mentioned that it's been, I think, over 3 decades, you said. And over that time, have there been changes in the way that this treatment is implemented?
Another great question. The essential components and the structure of the treatment have remained more or less the same, but we have learned a lot about how to apply it to different populations and the nuances that are different depending on the circumstances of the trauma or the population. So, for example, we've developed manuals that are available on tfcbt.org that address issues that children who've experienced racial trauma may experience. We have a manual for children who have developmental disabilities that addresses some of the special issues for that population. We have a manual for LGBTQ youth and their caregivers that addresses family acceptance and other issues that may be important for the particular population. So we have quite a number. We have another manual for children in foster care and children from military families. So we recognize over time that there are special issues and special considerations for different traumas that children have experienced or different populations of children. Um, but we still seem to go back to the same structure and components of TFCBT.
Mhm,
There are some things that we've learned over time that are important depending on the particular family and particular traumas that you're addressing in treatment.
Yeah. As we wrap this up, is there anything else that you'd like to convey about TFCBT? Anything that I haven't asked that you think would be important for people to know?
Well, I think the most important thing for therapists to know and for parents to know, and as many people know in this field, trauma is something that can be very, very difficult and can result in significant mental health challenges. But it is also something that people overcome. And children are particularly responsive to treatment.
Mhm.
So I would encourage people to be very optimistic. Sometimes you read a history about a child and all they've been through, and it's hard to imagine that they can overcome these experiences. But I've seen that happen again and again. And so I would be really encouraging therapists to be optimistic about the capability of children, along with the support of their caregivers, to really lead healthy, productive lives despite adversity that they may have experienced.
I love leaving on that optimistic note. So with that, I'll say thank you so much for sharing your time with us. I'm so glad that we were able to talk about TFCBT today.
Thank you so much. And I appreciate the time and, of course, the organization of ITSS that offers so much to clinicians in the field.
Thank you.